Welcome to the Radiology Review Podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review Podcast. On this episode, I will continue our discussion of sarcoidosis. The previous episode discussed sarcoidosis of the heart and chest. On this episode, we will discuss sarcoidosis of the central nervous system. A free downloadable study guide is available on my website, theradiologyreview.com, reviewing many of the topics of neurosarcoid that are discussed on this episode. Again, this will be presented mostly in a question-answer format. I will pause briefly after each question, but if you need additional time, go ahead and hit the pause button while you think about what the answer may be. Without further ado, let's get started. Neurosarcoid has been termed a great mimicker in the brain. The imaging appearances of neurosarcoid are commonly nonspecific for sarcoid versus other entities, so it is important to know differential diagnoses for various brain findings that we will discuss in this episode. In general, if they show you a brain finding and they also show you images of the lungs that demonstrate bilateral hilar, adenopathy, and mediastinal adenopathy, sarcoid should be high on your differential on board exams. Similar to the last episode where I said hilar findings plus heart findings should make you think of sarcoid high on the list of possibilities. For today's episode, CNS findings plus hilar adenopathy should make you think sarcoidosis. That brings us to the first question I will ask. What is the most common imaging manifestation of neurosarcoid in the central nervous system? Think about that one more time. What is the most common imaging manifestation of neurosarcoid in the central nervous system? The most common manifestation of neurosarcoid is probably multiple enhancing dural-based masses. Other common presentations include thickening of the infundibular stalk, lesions, whether nodular or diffuse, along the pial surface, cranial nerve enlargement and enhancement, or parenchymal masses, but probably most common would be multiple enhancing dural-based masses in terms of neurosarcoidosis. Next question. What percentage of neurosarcoid patients will have an abnormal chest radiograph? The answer is that about 90% of neurosarcoid patients will have an abnormal chest radiograph at time of neurosarcoid presentation. On board exams, if they show you a CNS finding plus an abnormal chest radiograph, you need to consider sarcoidosis. And remember from the last episode that sarcoidosis patients most commonly present between the ages of about 20 and 40 years old. So if they show you an abnormal brain finding and an abnormal chest radiograph in someone who is about 20 to 40 years old, that should further elevate in your mind the possibility that sarcoidosis is the underlying cause and the answer to the board exam question you are being presented with. Next question. What percentage of patients with sarcoid will have symptomatic CNS involvement? To phrase that slightly differently, how common is it for sarcoid patients to have symptomatic CNS disease? The answer is that this is relatively rare, and only about 10% of sarcoid patients will have symptomatic CNS involvement. Up to about 50% of sarcoid patients will have CNS findings on autopsy. So that tells us that most commonly CNS manifestations of sarcoid are clinically silent. Only 10% of all sarcoid patients will end up having symptomatic CNS involvement. So most commonly the CNS involvement is clinically silent. Next question. What is the most commonly affected cranial nerve in patients with neurosarcoidosis? The answer is that facial nerve involvement is most common in patients with neurosarcoid. Bilateral facial nerve palsy should make you think of potential neurosarcoidosis, and this may happen in up to 1/3 of neurosarcoid patients. If you are presented with a board exam question that asks you about bilateral facial nerve palsy, neurosarcoid needs to be high on your differential. Next question. Basilar meningitis on board exams should make you think of sarcoidosis versus what other entity? Now, of course, there are many causes of basilar meningitis, but most commonly, you should consider sarcoidosis versus one other entity in terms of board exam questions. The answer is that basilar meningitis should make you think of sarcoid versus tuberculosis. Okay, those are probably the two most common entities that you would be asked about in terms of basilar meningitis. If you have basilar meningitis and hydrocephalus, think tuberculosis. I'll say that one more time. Basilar meningitis plus hydrocephalus should cause you to think about tuberculosis. Note that these entities can also cause secondary CNS vasculitis, which would present on imaging with beating of the CNS vessels and possible focal vascular occlusion. So again, basilar meningitis plus hydrocephalus, think tuberculosis. And realize that basilar meningitis can have a secondary CNS vasculitis, so you need to evaluate for that as well. Next question. Sarcoidosis can also present with diffuse dural enhancement. What are other differential considerations for diffuse dural enhancement? Diffuse dural enhancement should make you think of intracranial hypotension, which in addition to the diffuse dural enhancement would also show enlarged cavernous sinus and a sagging brainstem. Diffuse dural enhancement can also be related to dural metastatic disease, postoperative status, or sarcoidosis. And typically sarcoidosis would show some nodularity of the dural surface, but that is not requisite. Next question. What are common entities you should consider when you see a thickened pituitary stalk on MRI? And this is a high-yield topic, so common entities to consider when you see a thickened pituitary stalk on MRI. Towards the top of the list, I would propose are lymphocytic hypophysitis, eosinophilic granulomatosis, sarcoidosis, and pituitary adenoma. Lymphocytic hypophysitis is often a diagnosis of exclusion because it is idiopathic. So before you would reach a diagnosis of lymphocytic hypophysitis, you would need to exclude other common entities to include sarcoid, a pituitary adenoma, eosinophilic granulomatosis, and other less common etiologies. Next question. What are common differential diagnoses for cellular/paracellular lesions you should remember for board exams? And can you think of a mnemonic for this? So one more time, what are common differential diagnoses for cellular and paracellular lesions? An easy way to help you with this is the mnemonic SATCHMO, SATCHMOE. And I suspect many, if not all of you, have heard of this before. But if you haven't, it's probably worth memorizing because it does help you present the differential diagnoses for cellular and paracellular lesions. So let's go through SATCHMO one by one. Again, SATCHMO is SATCHMOE. The S in SATCHMO stands for sarcoid, or cellular tumors, which means adenomas. So S, sarcoid or cellular adenomas. A, aneurysms. T, teratoma or tuberculosis. C, craniopharyngioma, chordomas, or cleft cysts, meaning Rathke cleft cyst, RATHKE, Rathke cleft cyst. H, hypothalamic glioma or hamartoma of the tuberosinium. M, meningioma or metastases. O, optic nerve gliomas. E, eosinophilic granuloma, also epidermoid, dermoid, or teratomas. That's a lot to take in. This is available on the free study guide that you can download from the radiologyreview.com. And I think it will be beneficial for you if you can recall the SATCHMO differential diagnoses for cellular and paracellular lesions when you take your radiology board exams. So go ahead and hit rewind and review those again, or download the study guide and review them in written form. Next question. Sarcoid granulomas in the hypothalamus can cause diabetes insipidus. What are clinical manifestations of diabetes insipidus, and what is the underlying mechanism that causes diabetes insipidus? First, classic symptoms of diabetes insipidus are polyuria and polydipsia, and the underlying cause is resistance to or deficiency of antidiuretic hormone. So when antidiuretic hormone can't do its job, either because there's not enough ADH or the body becomes resistant to ADH, people end up with diabetes insipidus, which manifests with polyuria and polydipsia. And as a reminder, polydipsia is abnormal thirst. So patients get really thirsty and they also have frequent urination. And that should make you think of polydipsia. And one cause of diabetes insipidus is a sarcoid granuloma in the hypothalamus, but other hypothalamic lesions can also cause this. With neurosarcoid and diabetes insipidus, the cause would be a central CNS process due to the central lesion, which in this case would be sarcoidosis involvement of the hypothalamus. That causes ADH deficiency, and this is different to peripheral resistance, where the body becomes desensitized to ADH, and peripheral resistance causing diabetes insipidus would be more common with things like chronic kidney disease, pregnancy, or lithium use. So diabetes insipidus can be central or peripheral. Central causes commonly refer to hypothalamic lesions that interfere with ADH production or release. Peripheral causes are related to desensitization of the tissues to respond to ADH. Central causes you should think of structural CNS lesions. Peripheral causes tend to be more systemic, like chronic kidney disease, pregnancy, lithium use, among other etiologies. Next question. Besides neurosarcoidosis, what are other entities that can cause central diabetes insipidus? Remember that I said central diabetes insipidus should cause you to think about structural abnormalities of the hypothalamic region, and common differential considerations for central diabetes insipidus should include craniopharyngiomas, germinomas, and those are the most common primary lesions. Also, various metastatic lesions can cause this, in addition to tuberculosis, Langerhans cell histiocytosis, trauma, and of course, neurosarcoid. Next question. Neurosarcoidosis is commonly treated with what therapy? The answer is that neurosarcoidosis is commonly treated with corticosteroid therapy. And after corticosteroid therapy, you may see decreased or resolved enhancement of CNS lesions. Let's talk now about neurosarcoidosis in the spine. And neurosarcoidosis of the spine will most commonly involve the spinal cord, and most commonly the cervical or thoracic spinal cord. You often see this in a more elderly sarcoid patient, and neurosarcoidosis of the spinal cord can look like just about anything, and you should evaluate for enhancement or enlargement of the spinal cord in really any location. This is often very nonspecific, but again, if they show you hilar and mediastinal lymphadenopathy, and then they also show you abnormal enhancement or enlargement of the spinal cord, neurosarcoidosis needs to be on your list of differential considerations. That's all I'm going to say about neurosarcoidosis in the spine. Let's talk about neurosarcoidosis in the head and neck. There's a little bit more to discuss here. So sarcoid can involve basically any structure in the head and neck, including the eyes, the ears, the sinuses, the airways, the vessels, the glands, and so forth. But what head and neck sites are most commonly involved with sarcoid? The answer is that orbital involvement is probably the most common, and this is most typically extraocular, to include involvement of the optic nerve and or lacrimal involvement, but you can actually also get sarcoid involvement of the eyeball, and that can cause uveitis. And if a patient has sarcoidosis of the eyeball/uveitis, you can have visual changes, including floaters and eye pain and other manifestations like that. On board exam, sarcoidosis is in the differential consideration for abnormal enhancement of the optic nerve, abnormal enhancement in the eyeball itself, as well as extraocular muscular enhancement. Next question, and I also talked about this on the last episode, so if you listen to that, take this as an opportunity to see if you learned. What is the Panda sign? Again, I think the Panda sign is really important for radiology board exams, and the Panda sign is a gallium-67 nuclear medicine scan that shows uptake of gallium-67 in both lacrimal glands, both parotid glands, as well as physiologic nasopharyngeal uptake, and the combination of the bilateral lacrimal, parotid, and nasopharyngeal uptake is the Panda sign because it looks somewhat like a panda, and it is something that should cause you to think about sarcoidosis in addition to lymphoma and some other entities. If you do not know what the Panda sign looks like, go do a quick Google search or open a radiology textbook and find out what this looks like. I sort of just answered this, but I'll ask it again anyway. What are other differential considerations for the Panda sign? Besides neurosarcoidosis, the Panda sign should also make you think of lymphoma as well as Sjogren's disease. Those are the three things I would have at the top of my list: Panda sign, sarcoidosis, lymphoma, Sjogren's disease. Next question. What are differential considerations for bilateral lacrimal gland enlargement? Because we are talking about sarcoid, and I just mentioned the Panda sign, we already know sarcoid is on there. You also need to think of lymphoma and Sjogren's disease. This is just a reminder that you may not be given the full Panda sign where you see the parotids plus nasopharyngeal and lacrimal gland uptake. If you only see an image, perhaps an axial CT or MRI image that shows that both lacrimal glands are enlarged, remember, this is part of the Panda sign. Therefore, differential considerations include sarcoid, lymphoma, and Sjogren's disease. Next question. Sarcoid involvement of the thyroid most commonly looks like what on imaging? The answer is that sarcoid involvement of the thyroid is highly nonspecific, and it will show you thyroid enlargement with possible thyroid nodules. You also may have coexistent cervical lymphadenopathy. This can therefore present similar to thyroid cancer, so you typically would need biopsy to differentiate a primary thyroid neoplasm with cervical metastatic disease versus sarcoidosis. And if you do a biopsy and see the typical non-caseating granulomas and you have the appropriate clinical history, you could reach the correct diagnosis of sarcoid. Next question. What is the top cause of calcified lymph nodes in the head and neck region? Think about that one more time. What is the top cause of calcified lymph nodes in the head and neck region? What I would remember for board exams and what I've read is that the top cause of calcified lymph nodes in the head and neck region is Mycobacterium infection. Other common causes include sarcoid, treated lymphoma, metastases from various cancers that include thyroid cancer. But the top cause to remember is Mycobacterium infection. Let's leave it there for now. More episodes on sarcoidosis as well as other high-yield topics for radiology board exams will be forthcoming. I hope this is helpful for you. Thank you for listening to this podcast. Remember to study hard. You have to study really hard to succeed on radiology board exams. If you prepare sufficiently, you will succeed. Please visit my website to download the free study guide on neurosarcoidosis. And you can also find other free study guides I've made available on my website, theradiologyreview.com, as well as other free radiology and nuclear medicine board preparation resources. If you have any questions, comments, or suggestions for improvement, you can find me on Twitter at RadRevPodcast or send me an email at theradiologyreview@gmail.com. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.